Welcome to the Nurse Coach Duo. We have an exciting episode for you this week. Dr. Rebbecca Hertel has returned. We had her on before and she talked about all things perimenopause. We'll put a link for that episode in the notes. But this time she's talking all things hormone. It's a bit of a long one, but trust me, you will want to stay till the end. We couldn't cut one single word of what she had to say in this podcast because it was all so important and so informational. So if you've been confused by all the information out there around menopause, perimenopause, and how to treat it with hormones, you are in the right place. We're tackling so many great topics around hormones and really cutting out all the fluff and just real talk. Dr. Hertel is an expert at the real talk and really makes it all make sense. So let me tell you about Dr. Hertel if you didn't see the last episode or if you don't know her. Dr. Rebbecca Hertel is a DO. She is a board certified osteopathic family medicine physician and a certified menopause practitioner. She's also the founder and CEO of Osteopathic Midlife Health, a telemedicine practice dedicated to midlife and menopause care. With over 20 years of experience, Dr. Hertel has provided passionate, patient-centered care across all of life stages since completing her residency in 2009. A passionate advocate for women's health, she is committed to advancing education and awareness about the unique changes women experience during perimenopause and menopause. Dr. Hertel regularly teaches medical students and she educates colleagues to improve understanding and care in family medicine. Beyond her clinical work, she delivers menopause education to providers, students, and communities through lectures, panels, and podcasts. Dr. Hertel has a large social media presence on multiple platforms where she shares valuable insights, resources, and support to help women thrive in midlife and beyond. And we will be sure to include all of that information in the show notes. Additionally, Dr. Hertel is a co-host and co-owner of the podcast, The Dusty Muffins, which is a really great podcast that you will want to check out. Dr. Hertel is the provider that every woman deserves. But as a reminder, she is a doctor, but not your doctor. As with all of our podcasts, this information is for education purposes only. It's provided to you to give you the support that you need to advocate for yourself. So please take this information, take it to a provider that you trust, and get the care that you deserve. And please, again, as always, don't forget to subscribe. Before we dive in, just a quick reminder. This episode is for educational purposes only and isn't medical advice. If you're dealing with a health issue, please check in with your healthcare provider.
Hi, welcome to the Nurse Coach Duo. My name is Angie McGuire. I'm the owner of Coach Angie in Oak Park, Illinois.
And hi, I'm Jen Schroer, the owner of Clarity Health and Wellness. And today on the Nurse Coach Duo, we have Rebbecca Hertel back with us today. We're super excited. Thank you for joining us again.
Thanks for having me again. It's my
Yeah.
pleasure.
Oh my gosh. Well, it's as we know from the last episode, you're a menopause specialist. We had such a great conversation. You're so easy to talk to about this. And it's just, Angie and I really focus on real talk and real conversations. And I definitely feel like whenever we talked to you last time, that is exactly what we had. So we are super excited to have you. We are recording this during September, which is Perimenopause Awareness Month. It'll be airing in October, which is Menopause Awareness Month. So never a better time for us to be talking. And we really wanted to focus on hormones. We have so much information out there right now, just too much, right? About what hormones are, what they're doing, where we're at. And so we threw out, asked people to send in questions, and we really just want to kind of get down to, I think there's enough of what is estrogen, estrogen's important, what is progesterone, progesterone is important. We know those kind of things, right? And if you don't, we can certainly send you to references. But I really want to just kind of dig into the questions that people have because there's so much confusion.
Yeah,
Sound
absolutely.
good? Yeah.
Let's
Awesome.
do it.
So let's just start with it, right? So we'll talk about the three main hormones and how do we get started and what is hormone stacking? That's a big question. And I've heard you talk about it before as
Yeah.
well. And kind
Yeah.
of what's your recommendation about where to start if you are ready to go on the hormone journey for your perimenopause and menopause?
Yeah. So interesting, we all a few of us got together, several of us got together in, this menopause land, and we kind of talked about renaming these hormones, or not necessarily renaming them, but on social media, you are very limited on the words that you use to describe these types of three hormones. You can't say sex hormones and things like that, or you get shadow banned. So we talked about, okay, well, let's just name them. They're progesterone, estrogen, and testosterone. So PET, progesterone, estrogen, testosterone. That's it. They are human hormones. We all need them. And so those are the three that I use in my practice as well. And I love the hormone stack. Part of it was my education, and it just makes sense to me. So hormone stacking is really referring to not starting more than one hormone at a time and stacking them on top of each other. So I start with one, and it really depends on the woman's hormones and what stage of their menopause journey they're in as well. So definitely they're going to get, estrogen or progesterone or testosterone. And it really just, I don't necessarily have one way I do it. So all three of us have talked about how important it is that we treat each woman individual, which I do. They're all, you've heard me say you are all are your own little unique unicorns, because it's true, right? I don't know what your receptor is going to do versus your receptor versus Angie's receptor. We're all a little bit different. And and every time I treat a woman, I'm telling you it is different every single time, and which I really enjoy doing. So how I do that is typically, so let's go with a perimenopausal woman first, since it's perimenopausal month when we record this. And usually those women, they're not always flashing. Some of them are, depending on what stage, but let's say early. They're still cycling fairly regularly. And this is a big generalization as well. They typically are starting to lose their progesterone first. That's why their periods are getting a little wonky at first. So a little closer, a little further apart, a little heavier, and they're starting not to sleep well, and or they're maybe having some mood changes. So sometimes in those women, progesterone is where we need to start. And these are women with intact uterus. So that's where we're talking about their cycles. And they'll typically do really well on just a nightly micronized progesterone, as long as they can handle some of the side effects, and not everyone will get them. Then I'll start there. Sometimes they will sail on into the sunset with a micronized progesterone and do fantastic. And I don't have to do anything else. Sometimes it's a lot more difficult than that. So, once we've gotten a nice progesterone, then I may have to add sometimes just the testosterone in those early perimenopausal patients, which is off-label, because we all know it's in postmenopausal patients for low libido. So this is off-label, but I find that these women in peri do fantastic on a little bit of testosterone even before I'll start estrogen. And a lot of times I don't need to start estrogen for a while. Now, if that perimenopausal patient's having hot flashes, dry skin, all of the low estrogen, and a lot of times it is happening during their luteal phase when their estrogen is low, I will cycle their estrogen. And sometimes I'm cycle estrogen without progesterone or testosterone because they're still cycling. So I know that they're getting enough progesterone, but they just need a little bit of help. So if they're flashing that week before, then I'll give them, a patch of gel spray, and they'll just use it that week before and sometimes that week during, and then they're done. Sometimes they just get vaginal dryness, and so we cycle the vaginal estrogen. And it's amazing. It is, I would say, one of the things with vaginal dryness is one of the issues that we don't talk enough to in our early perimenopausal patients. We're assuming that if they're having cycles, why in the world would they be having vaginal dryness? But I can't tell you the amount of women that tell me, you're right. I do get vaginal dryness the week before my period, and then it's gone. And so I'll cycle the vaginal estrogen for them too. Or if they like it, then they can use it all the time. So that's kind of where I start. I know it was kind of a long-winded answer to that, but that's what that stacking means. So depending on the symptoms that we are trying to obliterate or at least modify and support or optimize is a really great way of describing it as well. That's usually where I'm going to start.
Yeah, such excellent information. And it is a lot, right? There's a lot of information, and it is
Yep.
management, right? It's
Yes.
not, when we talk about hormone stacking, it is starting one, and then your patients, clients have to follow up. And so you're in
You
this
do.
together.
Yeah.
And I think too, we're not always used to that in medicine, right? We go get our stuff, we hope we feel better,
Yes.
and it's just, it can be, it's both of our responsibilities, especially the patient's journey, right? To
Yes.
understand
Yes.
and I think that's where the shared decision making comes in right off the bat, right?
Yeah. Yeah.
And then just all that what you've said, it's just it confirms the importance about this growth of menopause medicine and finding a practitioner that really understands and will take the time
Yep. And who has
and
the time?
understands what each of the pet
Yeah.
hormones do,
Yeah.
right? And
Yeah.
and I know there's not as many out there that we would like, right? And
Yeah.
there will be in the future, hopefully. But just so backing up a little bit, if your patient doesn't, sail off into the sunset into that magicness of and what are some of the most common side effects or complaints that correlate with each hormone?
Yeah. So when you start it, like what types of things? So
Yes.
part of that, at least in my patients, my initial visit, which is an hour long for a reason, because there's so much education and it's amazing how fast an hour can go.
Mhm.
We talk about exactly each one of those, irregardless of which one I'm going to start necessarily. And sometimes we don't start anything, honestly. Sometimes they
Mhm.
feel great when they see me and we just journal for until they start to not feel well. So that's also one thing. And we'll touch base kind of back up again, kind of about perimenopause and why, women get so frustrated in this stage. But when we start estradiol, I always say to them, okay, listen, if it's too much, then your breasts are going to hurt. Maybe you're going to start bleeding. You're going to get ragey. You're going to get bloating. I also am a firm believer in low and slow. I start at the lowest dose and work up. I know there's some thoughts out there. If depending on your hot flashes, you can start in the middle of the road. I've never regretted starting low because a one person's 0.025 might be the next person's 0.05 or higher, and you're going to miss it. And if you give them too much, they feel terrible. So I still just start low and slow. But I also make sure I tell my patients, like, just bear with me. It may take a little bit of time until we find it, but we don't want to overshoot it. So estrogens that typically you're bleeding, your breast tenderness, you're bloating, and your mood, if it's too high. The progesterone, the micronized progesterone is taken orally. The most common side effects with that is going to be water retention. So you might feel like a little puffy everywhere, a little bit of bloating, sometimes some gas. Some women, it stimulates their appetite a little bit. I do tell them, give me 4 to 6 weeks on it. I don't want you to be uncomfortable. Some truly are uncomfortable, and we can give it in different ways. But a lot of patients after several weeks, all those symptoms will go away or calm down a bit, and then they do okay. Sometimes we do have to introduce it slower. So if they're still cycling, it's okay to do that, right? You can do micronized progesterone in different ways. You can cycle it. You don't have to necessarily do it every day, and just go low and slow until they can build up the ability to take the medication and tolerate it. Testosterone, most common side effects when I talk to women about starting testosterone are going to be oily skin and acne. That's the most common, even at a low and slow, which I'm very conservative when I start. Some women, it's honestly a smear. Some it's a lot that that they end up going to. But again, you don't want to over treat because they'll start breaking out. They'll get oily skin. Their hair will start thinning. I haven't had it. I do have some women that are very, very sensitive to testosterone and they'll notice that they're having some shedding. It that sometimes it's hard to understand. Is it normal shedding from like other stressors? Or if you're still perimenopausal and you're having a lot of loop cycles, which are up and down, you can shed just from those hormonal fluctuations. So it's really important to journal these things and where are you in your cycle, in relation to just kind of normal stressor shedding, and which happens a lot kind of as we're, I think, transitioning through midlife. But those are the most common symptoms. Typically, when you start to get like, clitoral megaly, that is going to be at higher doses, or if you are applying the testosterone straight on to that area, which I don't ever recommend. So, voice changes in some women. At the Menopause Society, there was an amazing lecture last year about voice changes with testosterone. It's typical that we see that at the higher doses, but it can occur even in the therapeutic higher doses. So if I have someone I'm starting on testosterone and they are a vocalist, I have them be very cognizant of any changes in their voice because then we have to either go back down or stop it. If you do it early enough, it is reversible, but if you let it go for a while, it's irreversible.
Yeah. It's so interesting that you bring up a lot of that because, so many women, I don't think they don't really even track their cycles yet. And you can learn so much by doing that.
You
And it's like,
do.
oh, now I'm going to go on this medicine and now I have to track it even more because
Yes.
it is
Yes.
not, it's not one or done. It is not one
No.
or done.
Well,
I
we're
mean, there
used
might
to
be a few
checking
people who
it.
are lucky, right?
Yeah, yeah, and we're used to checking it to like not get pregnant, right?
Right.
Like, okay, I got now I'm like, well, yes, in perimenopause you can still get pregnant, everyone. That's like for sure.
Yes.
And menopausal therapy is not contraception, so you can still get pregnant on menopausal therapy. But yeah, exactly. We've been out of that. Like we've already had babies, most of us, and we're not doing that anymore. And our cycles were just like, okay, whatever. Maybe it's on a period app or something like that, but you're not tracking your symptoms with your cycles. But it's so important. So when I ask, well, is that happening like right before? So most of my women, even today, I had a full morning of patients and they're like, oh, I don't know. I'm going to start tracking that. I'm like, okay.
Yeah, absolutely.
You know,
Well, and I think it brings some conversation about the different forms of the hormones that you can get as well. Because, I was at a conference last night and they were talking when somebody kept bringing up pellets. And I just think that I mean, I'm not going to get in a big, like, are pellets good or bad conversation,
right.
but like, I do think there's such a reason to start on something topical to figure out how it affects you. Because if you
Yeah.
put a pellet in, you're stuck with it for 3 months,
You're,
right?
yeah, yeah, and it's expensive. I mean, so if we think about and there are some really, really great practitioners that do pellets and they do it really, really well, and some women really love it. So we'll start with that.
Right.
But again, like let's talk about the FDA approved. They're not FDA approved. You don't know where you're necessarily getting them from. I'm confident that the practitioners that do a good job have really great resources. But I don't want incision marks in my backside for the next 40 years. I just don't. I don't like shots. I get them. I have about whatever. But I'm like, I am not willingly going to lay down and let someone make a little incision in my backside for the next however many years. But you're right. Once it's in, it's in.
Yeah.
If you have side effects, sorry for you. Or if it migrates and, all of those things. And it's expensive. It's expensive. I can get
Yeah.
you estradiol for nothing, as long as your insurance covers it. Or you can also get it through some other, HRT Club, Cost Plus drugs, things like that, that are so, they're just cost friendly and way more economical than doing the pellet. So, and
Yeah.
that's kind of, what I have to say about that. But yeah.
Yeah.
And so, even a pill, whether it be an estradiol pill, a patch, a gel, a spray, the vaginal ring, those are all, even the vaginal ring you can get through, transition pharmacy for a really reasonable cost.
Yeah. And I think that, I think it's interesting that we hear so much, like, especially on social media right now. I feel like there's this big, like, trend of everybody, hormones, 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 and it's the only way, it's the way. But people are thinking, oh, I'm going to go on this medication and everything is going to get better. And for
Yeah.
some, maybe that happens. But what I love, so you mentioned us a couple of times earlier, and I'll just bring up that you were talking about your dusty muffins. So the
Yes.
podcast that you have with
Yes.
your Menno besties.
Yes.
And you guys are very vocal and honest about how, even though you're on hormone therapy, and we'll talk about your journey,
Yeah.
not theirs, since we're talking with
Yeah.
you, even though you're on hormones, you still struggle with brain fog,
Yes.
with different symptoms. So can you talk to that a little bit? Just kind of
Yeah.
explain how it maybe yes, we'll get rid of one of your symptoms completely, but maybe we're also going to have to change doses, work with what's going
Yes.
on, and do some other things besides just hormones.
Yes, absolutely. So I've probably been on this journey maybe 43, 44. I can't remember how old my son who's 8, I had him when I was almost 40. So I did the perimenopause and postpartum thing. And so My main symptoms that I struggled with were at that time anyway, was the horrific brain fog, hot flashes, night sweats, the vertigo and migraines, and a lot. I mean, it was crazy. Vibrations, all the things. It was just the craziest thing. But the brain fog for me would have put me out of my practice, no doubt. And so I, added things slowly throughout these last, I'll be 48, or I am 48, I'm sorry. So I added things slowly throughout those 5 years. And I still, and now I'm late perimenopause. So I go anywhere between 4 to 6 months. I went 290 days once and then started cycling regularly for 4 months straight. I couldn't believe it. And so with the menopausal hormone it's a cushion. So it's a cushion to hopefully get rid of some of the devastating symptoms that you can't function in life or you well in. And so, but in perimenopause, on hormone replacement, you're not shutting your ovaries down. So you're really just providing a cushion kind of following you around, right? If you fall, I've got your trampoline. If you fall, I've got your trampoline. So you have something to fall on, right? And that's kind of how I think about it. Like I know I'm still going to go up and down. I think in June I had a loop cycle that I caught and my estrogen was almost 600. So yeah, it was it was terrible. And so you're like, oh, okay, well that makes sense. That's why I was feeling that way. And so I know that there are times that I am still going to cycle or am cycling or it's low, right? I will get vibratory sensations. I'll get like a flash of vertigo. I'll get the dropsies, like everything's dropping. And one of the things I was talking to you both about was that I still don't have the same fluidity and just kind of like brain. I can answer that question really well. I have to be very prepared for my podcast, for webinars, things like that, because that's just my perimenopause. My brain just, the synapses are just a little slower than they used to be. And it's really frustrating. It's very embarrassing because you'll lose a word and you're like, I have no idea what I was just going to say. It's gone. And I'm just like, sorry. It would be far worse for sure. Have if I wasn't supported. And I think, am I optimized? I feel like I'm optimized for where I'm at in my transition. I do have to fine tune things every now and again and change things up, but it's not going to be perfect. And I think that's the hardest part to get across to our perimenopausal women is it probably isn't going to be perfect. And it might be. I have some that, boy, they do really great. And then there's some that are a little bit harder. And I think there are some things that even on hormones that we may still have to deal with, and that's okay. It's not a failure. You're still optimized for where you're at in your transition, along with lifestyle modifications, getting sleep, making sure your stress and anxiety are taken control of. Your nutrition is huge. I've never needed so much sleep. Like my circadian rhythm is totally different than it was even 5 years ago, right? And in my ability to stay up or to tolerate certain things if I haven't had sleep. So all of that mixed into it plays a really big part into that transition. So I just think that with our perimenopausal patients, I'm always like, you've got to give yourself grace. Like, it doesn't bother me at all. This is all part of it. I think it bothers them if they're just like, oh my gosh, I'm still struggling. Oh my gosh, I'm still struggling. So having those green scale scores is helpful because I can say, listen, you were a 26 the last time I saw you, and now you're down to a 20. We did do something. Like you did something. We did something. Maybe you did it on your own and we just got lucky. I don't know.
Yeah.
Maybe you went to bed better. So I think that is the hard part is just remembering it probably isn't going to be perfect and we don't know what it's going to be like on the other side. We may not feel back to where we were at 35 or 40 in our menopausal state. It may not be perfect the way that we wanted it to be. We're just not sure at once you finally get to menopause and even 5 years out, some women start to feel better 5, 10 years out. Some don't, depending on, you know, genetics and lifestyle and all the things.
Yeah. Again, so much amazing information and we could go on and ask so many questions from there, but I want to celebrate the trampoline analogy.
Yes.
Yeah.
Because I think that's really important to think about. Like it is really sort of this base of,
Yes.
so you won't go as low as you would if you
Right.
didn't. have it, right?
Right.
So, and I'll just, tell my little story real fast. In my perimenopausal, late perimenopausal, I am menopausal now, but that late perimenopause was my mood around anxiety and feeling depressed, and in a way that I'd never felt.
Hmm.
In that last year before menopause. And that's where I just said to my doctor, and she was like, okay. I mean, she didn't even, I know a lot more than I know a lot more now than I did 2 years ago.
Yeah.
But, and I'm happy that I do, and I want to share it with everybody. But like, that is one of the reasons I was like, I need some estrogen. I need an estrogen patch. I need progesterone. And she was
Yeah.
like, okay, okay, and then, it's just interesting. But that was I said, I don't ever want to feel the way I did when I got my period last time. When I went,
Yep.
I
Yeah.
don't ever want to feel that way again. And I
It's
never did.
terrible.
I
It,
never did. The patch gave me that, that support that I needed through those last really 12 months. So anyway, so much we can talk about, but one of the questions that we got, from our listeners or friends, or, when we sent out our ask, but because we're still talking about taking hormones and side effects from them,
mhm.
it at what point would you have someone stop their hormones? Like, is there any
Sure.
like the side effects that you would have, or you would just say, it's not, this isn't working right now. It may work in the future, right?
Yes.
But right now, they're not working. So if
Yeah.
you could just share a little
Yeah,
bit about that.
absolutely. I've actually, in the last probably 6, 8 months, have stopped two perimenopausal patients off their hormones. All of a sudden, their ovaries just started working. They're like, I don't think I need it. I think I feel worse on it. I'm like, okay, let's stop it. Let's stop
Mm.
it and journal and find out. Or
Oh my
there's
gosh,
so
I
many,
love that.
yeah, let's stop it and journal. Let's go through a few cycles and we can find out. And so that's also one of the big things that I talk about when I first see these and we'll go perimenopause and we'll go to menopause, is we may have to stop them at some time because giving you some support, all of a sudden your ovaries might be like, oh, all right, I'm going to start working again, right? Just like in our POI, premature ovarian insufficiency patients, they can still get pregnant when you start giving back their hormones. I always talk about contraception. Sometimes all of a sudden it kicks them back into working. And so they can ovulate. So in these peris, same thing. They can, and let me back up for a second because typically the symptoms are the delta changes. So you go from here and then your estrogen goes high and then it drops down. So usually the symptoms is from the delta change, from that fall of that rapid high and the kind of up and down. And so, but instead of, that just nice like little EKG, but if their ovaries all of a sudden start working again, I've taken them completely off or I've pulled one thing off. All right, you know what? I don't know. I'm okay with saying I'm not sure. I'm not sure which one is not working. So let's pull something off. Let's pull one thing off at a time. How do you feel? And that's sometimes they get frustrated, like, oh my gosh, and I'm just like, this is perimenopause, you guys. I can shut your ovaries down with birth control if you'd like me to. We can do that. That may be actually a really good option for you if we need to. And sometimes we exhaust all of the options first before we would, because they want to see it and they want to try it, and that's fine. And we're not married to anything. Nothing that we start, we can always stop, we can always change. So that's one thing. In menopausal patients and even in perimenopausal patients, if they have, you know, acute DVT, their calf starts swelling. Knock on wood, I've never had that. If they are having horrific headaches, migraines on the medicine, whether it be stopping or titrating down, again, that low and slow approach is super, super important because typically when you do it that way, you're not going to overshoot and make them feel terrible. If they're having really bad side effects, they're bleeding a lot. Now, with bleeding, we usually say, oh, that's high estrogen. Well, sometimes it's too much progesterone and we've made that uterine lining too thin. We actually have to give them a little bit more estrogen if they can't back off on their progesterone. So those are like little nuance things. Very rarely have I had to have them just like completely pull them off. Even if they are going for surgery, I am like, if you're on transdermal, it doesn't increase your risk. But if you take them off a week before they're having surgery, now they're all inflamed and all of these things. And I, I had a procedure done once and they wanted me to stop all my stuff. And I just like looked at her and I said, oh, listen, I'm a menopause specialist and I have a transdermal. And if you would like me to talk to the surgeon about the risks, I absolutely can do that for you, but that patch isn't coming off.
Love it. Stand up for yourself.
You
Absolutely. It's
know,
like, do
I
you
was
want
like,
me to
show me the
try?
data. Show me the data, first of
Yes.
all,
Right.
So,
Yeah.
so those are kind of, those like red flags, right? So horrific headaches, if you've got horrible bleeding, vision changes, chest pain, all of those things. And again, knock on wood, I can't tell you, I've not had anyone yet have any of those things. And so typically when we stop it or change it, it's tolerability. So if you have a menopausal woman who's been menopausal for a while, I have found in my practice, I have to oftentimes go really low and slow because their estrogen receptors are like, oh my gosh, we haven't seen this in forever. What is she doing to us? And so they'll get some nausea. They'll get almost like a little inflamed at first. So I have had them very, very low and so where even like it's a quarter of a patch, it's a half a patch. And there's, most of the patches out there, you can do that too because they're not the reservoir. So you can do that. And that works really well. And then they just slowly get tolerated. I mean, I have patients where it's been over a year where we have just finally gotten to a full 0.025 patch and it's just been tolerability. So that's typically what I see more often than not. But the big thing is just saying, these are medications that you can stop and change at any time.
Yeah.
So
I mean, if you're hearing anything else from this, it's that you gotta, it's trial and error. I mean, we
it
gotta,
is
and
a
you,
lot of trial and error. And I think they all come in thinking, I'm going to try it once
yeah.
and it's going to be great.
Mm,
And it really isn't, which, a lot of us, that's why we kind of do plans of care. It's not like a fee for service. It's like, you're going to see me 5 times in a year. Or if I see you for 6 months, it's 4 visits. Like this is a journey together. It's not just here you go and I'll see you later. You really cannot do appropriate care that way.
yeah. Yeah. So, I mean, like if you're going to a provider and you're not getting options, then we need a new provider, right? Like, I mean, this
Yeah.
is
Oh, yeah.
just like, obviously, if it works for you, great. But like if you're not getting any other options, I have heard of many, doctors that are like, I only do birth control, or I
Yes.
only do cream, or I
Oh,
only
yeah.
do this. So,
Yes.
the options are just so important and to know and to advocate for yourself. Like,
Yes.
I think all three of us would say that, scream that from the rooftops, because if you don't stand up for yourself and you don't come
Yep.
in and say, but what about this? And if your doctor's not willing to hear that,
Yep. Or
you
they don't
know,
have time. Like I
right.
get it. I still do an insurance
Absolutely.
model as well. It is difficult when you have to meet, the demands of how many patients you have to see a day and, every 5 minutes, 7 minutes, however you're doing that. And, so I'm going to say to those patients that you really have to book a visit specifically. Don't get in your annual exam or your physical or your PAP and be like, oh, by the way, I want to talk about perimenopause and menopause. I'm telling you, I spend that full hour and sometimes I need more time just to explain, especially in perimenopause, because I just feel we're so vulnerable at that stage and there's so much going on outside of our body and inside of our body that there's just so much support that you need.
Yeah.
And it's just really important. And you're right, it depends on, some practitioners are not comfortable treating perimenopause and they will not treat you with anything else than a birth control pill. And if that's what they're comfortable with, okay, that is fine. They don't do perimenopause care. So, and that's all right.
Yeah.
But you just have to ask those questions, I think, before you make those visits, especially if you're paying out of pocket.
Yeah. Can you dig into that a little bit for us with the birth
Yeah.
control? So like, either you're, and let's maybe start with scenario one, you're on birth control and your doctor's like, hey, stay on it until you get
Yes.
into
Yeah.
menopause, and then what you do after. And then also, should it be an option for people who weren't on it but are now going through perimenopause or are in menopause?
Yes, perfect. So let's start with those women, the easiest part, the women that are already on their birth control. If they are doing great and they're not getting sexual side effects, they are not getting vaginal dryness, they are not having mood changes or hot flashes through their birth control pill, because it is different, right? It is not estradiol. Now, there are some coming out that have the estradiol in, but that's confusing. So we're just going to say it's the synthetic form because that's what most of people are on and insurance covers. Say, I tell them you can sail on to the sunset on your OCP until the ripe old age of 52 or, whatever the average age of menopause is. We'll pull you off and put you on hormone therapy if that's what you want to do. And they're like, okay, great. Sometimes I have to add some vaginal estrogen to that because they're still getting vaginal dryness with their OCP. That's also okay. So that's that subset where they're already on it. They're doing great. We pull them off in the average age of menopause and we give them the decision, hey, do you want to go on menopausal therapy and or not? And the risks and benefits to that. Now, if you have a perimenopausal patient and you're trying to treat them, say they're having really heavy bleeding and funky periods and they're really just up and down, if they don't, an IUD is an option for that. There's a percentage of women that if you put in a progesterone IUD, it does shut down their ovulation. I believe it's about 20% or so. It shuts their ovulation down and they do better. But it's really great for that uterine protection, thinning that lining down works really well for some women. You may not shut your ovaries down though for that other, 60, 70, 80% of women. The other option is a birth control pill. So you can do a lower dose birth control pill on these women, or you can do a progesterone only pill on these women. And that will shut those ovaries down and make them behave just the way that you want them to, for the most part. You may have to support them in other ways. So if I give them a progesterone only pill that is a contraception, or maybe these women need contraception, right? So if we back up and say, do you also need contraception? If you need contraception and you're having wonky periods, then I'm going to do an IUD, a progesterone only pill, or a continuous combined pill. That's going to protect you. If they don't need birth control, then they have options. If they don't need contraception, then I'm saying, well, you could still do an IUD. You could still do a progesterone only pill. You can still do a combined, or we could try menopausal dosing and see. So when you do the progesterone only pill and it's contraception, you could add an estradiol patch if they get hot flashes. You could add vaginal estrogen. So you could still add some estradiol, the bioidentical estradiol, to those. And sometimes we do that if we can't get the bleeding controlled, or if they're having heavy bleeding, because the micronized progesterone doesn't always control it, especially when they're really heavy. But you can also use different progestins, not contraception grade progestins, and your menopause practitioner needs to know the difference in case you can get pregnant. So there are different types of progesterone that is synthetic, that's enough that is contraception, and some that aren't enough to be contraception. And you really have to understand that. They really need to be able to speak to you about that. And
And,
then your pills.
and before we leave that subject, I just want to ask, because you said when they get to menopause age, then I take them off. Why can't they
Yeah.
stay on it?
Yes. So as we age, our increased risk of blood clot goes up just naturally. Any estradiol that you take orally can increase our risk because it goes through the liver, can cause an uptick in our risk of clotting. Okay. And so that increases that risk. Not only that, but we typically don't need those high dosing. So I always give my imaginary graph here. I'm like, okay, baseline is menopause, nothing. You don't have anything. You have zero estrogen. Menopausal dosing, that's going to put us like up here, 40, oh, hopefully over 40, between 40 and let's say 80. Okay. Birth control is going to put us at like, I don't know, 100, 150 of estradiol or estrogen, let's say, because it's synthetic typically. And then pregnancy is way up here. So with each one of those, we do have a clotting risk, right? So we have menopausal oral gives us a small, but not zero. Your oral contraceptives will give you an even higher, not zero, and pregnancy is even higher, right? We forget about that. Like our estradiol and pregnancy is like insane, right? Or fertility too,
Yeah.
right? When you're doing IVF, I did that with our last one. And so, I mean, you want to talk about a roller coaster of just crazy in the head. That was true.
Yeah.
So that is typically
Okay.
why we don't need the contraception, number one, in menopause. Number two, we don't, the oral estradiol through the liver through that first pass increases our risk of blood clotting, and then just our own natural, aging too increases our risk as we age.
Perfect. Thank you.
Yeah, that was great. Um, One more question about that. If someone has a progesterone IUD,
Yeah.
can you also take an oral progesterone if you're having trouble with sleep?
Yes.
If sleep is your only, if that's one of your
Yeah.
only
Yes.
complaints.
Yes. And you can also take it if you don't have a uterus. So, yes, 100%, because the progesterone in that IUD is not going through the liver, breaking down, and then going into the brain and working on the GABA receptors. So, when a woman takes oral micronized progesterone, because birth control pill doesn't do it either. If you think of, so let's think about that. If everyone with an IUD and oral birth control, it worked like micronized progesterone, we'd have zombies all over the place, right? We wouldn't be able to function. So those types of progesterone don't do the same thing. They don't get broken down into that allopregnanolone and work on the GABA receptors in the brain. Micronized progesterone taking orally gets broken down. Even if you do micronized progesterone vaginally, I've had some feel like it still gets some sedating effect. Whether or not that's placebo, I'm not sure, but technically it shouldn't be as high because it doesn't get broken down the same way. So yes, that was a long answer to to your question. Yes, on an IUD you can do micronized progesterone. If you don't have a uterus, you can also do micronized progesterone as well if it benefits you.
I definitely think that's misunderstood
Yep.
across the board. I mean, a lot of
Yep.
this is, and so I'm just so grateful we're having this conversation
Yep.
and getting it all out there.
Yes,
Getting
and
all this.
I've even used in my bleeders, in my perimenopausal bleeders that are really having horrible periods that they're on a synthetic progestin to stop the bleeding because the micronized didn't work. I've had them use both because they're like, I can't sleep without the micronized progesterone. And I'm like, okay, I'll give you a little bit of that and just a lower dose of the other stuff. So,
Yeah, I'd love to also talk a little bit about because we're talking about it for perimenopause and managing these symptoms, right? And I know on your Instagram, you're very into like lifestyle factors and all these different things, and you've touched on them.
yep,
But what we're also hearing is that, it's going to help us not, not die of a heart or have lower risk of a heart attack, have better bones, have, lower risk of dementia, all these things. So
yep,
there's a lot of, longevity talk going on out
yeah,
there. And I feel like there's some confusion on, which form is the best? How high of a dose do I need? Do I need a high,
yep,
like all of it's just so confusing because you listen to one podcast and it's like, well, it's only oral, and you listen to another podcast and it's like, well, that's not going to give you enough dose, and we don't even know what dose you need.
yeah.
Can you clear any of that kind of longevity? Is it really like if you don't go on it during perimenopause, you really probably want to for healthier
Yeah.
lifestyle? Kind of
Yeah.
clear that up for
So
us.
yep. So one of my really great colleagues just, said this to me because we were talking about longevity and we're just like, and she was like, this is just this huge buzzword right now, right? And really what longevity means is making the changes so that you live healthier as you age. So hormone optimization is one of those things, right? That we know from at least the studies that women live longer, about 4 years longer on hormone therapy. Now, I do have women come to me, they're like in perimenopause and they want to get on it just because they want to get a step up. Yes and no to that. Really, the WHI gave us great data on that. And that data was that if you start within the first 10 years of menopause, you get your most bang for your buck. So you're okay in peri. You're still producing your own hormones, albeit they might be wonky. And that is a great reason if you need support through it. But you don't have to get on it because you're like, oh, I have to get on it now because I'm super afraid. Now, in the late perimenopause transition, that is when we lose our most bone, right? During that late perimenopause. So that's when I would say, what I to optimize bone health, resistance training, getting enough calcium in your diet, and, really maybe asking for that bone density. Although a lot of us in late perimenopause are not even 50 yet, right? You're going to have to pay for it out of pocket. You're going to pay for it out of pocket even in your 50s. But you're going to be hard pressed to ask a physician or any clinician who is not really in concierge that, hey, I want to get on estradiol to protect my bones because I'm now in late perimenopause. I don't know if we have enough data to even support that, I don't think it's unreasonable. It might be helpful. If it's too much, you're going to know you're going to feel terrible. So that might be a little bit of a controversial, talk. But if we lose the most bone during that time and we're doing all of the right things, I still have women that we finally got a bone density and even on, the lowest dose of hormones and they still have osteopenia. And we're talking about eating well, lifting, doing all the things. So where's that data? Let's start with the estrogen in the bones. We liked it above 40, so 40 to 80 without side effects, at least in my training. Now, if you pull some of the data though on the best bone protection in postmenopausal women, that best bone protection is estradiol levels of around 60. Now, I think anything is going to give you something. So, what I have been kind of discussing with my patients, taking the data, taking my teaching, and then just kind of a nuanced care to my patients is listen, if it's above 40, I'm like super excited and you're feeling better. Awesome. Could we maybe, and do we want to try to get you to 60 without side effects to see if we can maximize your bone protection? Most of them are like, yeah, I want to see. Okay, if you don't tolerate it, then we back you back down. Not a big deal. We can do that. So that's that for bones. And bones are huge. 30% of women that have an osteoporotic hip fracture die. So I cannot drive this home enough. And why we're not talking about it more than we are is beyond me. So cognition wise, we know that that can be also related to hot flashes. So uncontrolled hot flashes cause changes in our brain, just like uncontrolled hypertension or high blood pressure. And that causes white matter changes. They're called hyperintensities, which lead to like a vascular dementia as we're aging. So we got to stop hot flashes, period. No one should flash if we can help it, right? So whether you're using hormones or whether you're using different medications to stop your hot flashes, if you cannot take hormone therapy, we need to stop those. And we have different medications for that. So even for cognition, and there's so much on the forefront right now, Lisa Mosconi and all of that with the brain and dementia. There are some changes in like the tau and things like that if we're on hormone therapy, again, within the first 10 years of menopause. So even my peri patients who sometimes have the worst brain fog, it can still be helpful. It doesn't mean that you're having dementia, you just feel like you do. But over time, we have the decrease in or increase in cognition and that decrease in decline of cognition. So if that makes sense, takes longer, right, over time. And then heart disease, we know it's the number one killer in women. And the reason for that is, again, hot flashes change the way our vasculature. So again, it causes vasoconstriction, it causes our blood pressure to go up. And so if we have untreated hot flashes, that can also cause us to have earlier cardiovascular disease. So, but just over time, the changes as well, because estrogen is anti-inflammatory. So as we lose that, right, then we have increased risk of cardiovascular disease as well. And so again, within the first 10 years, so the WHI, although, it scared women inappropriately, we still gained a lot of information. And that information is that tenure within the first 10 years, you get your most bang for your buck. So perimenopausal women, you still have some time. We can use that type of medication to help support you, to be your trampoline so that you're not having these huge changes, but you still have time as far as longevity care and and optimizing those hormones so that you're not flashing is important. And yeah, that's kind of just what longevity is. And so anyone who does hormone optimization and menopause therapy, again, my colleague made that clear to me and it made sense. She's like, you're doing it. You're already doing it. So don't get caught up on all the buzzwords.
Exactly. Oh, so just another question about optimization of our hormones,
Yeah.
just to be the most, and you explained that so well. And, but so is it reasonable for me to go if I don't have a concierge and I don't, I've been put on, estrogen and progesterone, and I'm 6 months in, and I want to see where and I'm taking a patch, maybe my symptoms are better. Is it reasonable to ask for an estrogen level.
Yes.
And to look and to, you know, sort of, you know, everyone listening is going to understand why, because
Yeah.
we're not going to get that protection of our bones, our hearts, and, you
Yeah.
know, lots to come about our brains if we're not absorbing it. If we're on a patch, if we're not
Right.
absorbing it, we're not getting the
Right.
protection. So
You won't
how would
know.
we're not going to know, right?
Yeah.
So
Yep.
I thank you just for confirming that, because I've had this discussion, and I mean, it may be something that we have to pay out of pocket for, but it's probably worth it.
Yeah. Your insurance should cover that
Okay.
if they are putting the right diagnoses underneath the
Okay.
menopause. I haven't had one of my patients come back and their estradiol is not covered. And so you're right. From my training so far, I I don't know that we know the right answer to the estradiol dose for heart protection, for brain protection.
Mm,
I would say that my training was at least, over that 40. I think we're going to learn more. I hope that
mhm,
we learn more and we have more studies. The one for sure that I have been able to pull up is the bone protection at, like I said, 60, but you still get bone protection even over 40. So if we can get women up above zero, they're going to get something, right? So even the lowest dose patch, which there is a dose that's lower than the 0.025, is supposed to still be FDA approved for osteoporosis prevention. So again, it depends on how you're absorbing it. And in perimenopausal women, I still will offer them labs. I'm like, listen, as long as you know, it depends on what your ovaries are doing that day. If you know that, fine. We might catch a loop cycle, and that data is just kind of cool to see, you know. But in a menopausal patient, yes, you still fluctuate a little bit. You can still have some fluctuations, not a lot. What I have been doing in my own patients is if they're on a patch, I like them to do their levels right in the middle. I can't even tell you that I have any data on that, except for I'm seeing it in my patients. If they get it on the day they start their patch or the day that they need to change it, the levels are wonky. But if I get them right in the middle, it just makes sense to me clinically that they might be a little bit more level as far as where their estradiol is. And you're right. If we're weaning them up, and I'll use a patch for an example, we're weaning them up and they're still symptomatic and their levels aren't budging, then you guys, we got to change it. It's not working. We have to change the route, whether it be to a gel. And sometimes it's location. There's some patients that they're like, I'm on the highest dose of the gel and I just had to add a little bit more to my arm, which is off label because it's higher than the highest dose. But boy, that's where they're absorbing it. And estradiols look great now. And it's not too high. It's like 60, 70. They feel great, but they're on an off-label dose. And so it's really important that they are working with someone who understands that sometimes you have to use some things off-label. You just need to be very clear and just say, this is off-label. This is what the dose is FDA approved for, but you're not absorbing it there. And it's off-label for the forearm, for the gel. But boy, that just seems to be where you're absorbing it. So let's try it. As long as you're clear with your patients, that's why it's so nuanced and it's worth that investment if you're able to swing that to get, that type of care and just and nuanced care for women.
Yeah. I'm so glad that we covered that lab conversation because it really is one of those things that people, on podcasts and social medias, all the people that are talking about this, they were either one way or the other. There is
Yeah.
like,
And
it's
I
like,
don't think
how
there
can we
is
not have
one way or another.
no,
Yeah.
where's the
We have
middle
to take
ground
all of it,
here?
right? Like we have
Yes.
to take all of it. Like, what is this woman feeling? And what are the labs showing? And can we make it make sense? And so, at
Yeah.
least in my experience, I've had women, they feel great. Like they feel great at their highest estrogen, and that's just like where they feel good. And they feel really terrible when it drops down. And so, some women feel great when they're ovulating. Like they're just like, oh my gosh, I feel
Mm,
wonderful. And then
Yes.
they drop down to the luteal phase and they just feel terrible. So they really want those higher levels of E to make them feel good. And we don't necessarily need them to be at 150, I don't know. But I'm okay with like, all right, so maybe you're better at like an 80 or a 90
Yeah.
and you're not bleeding, you feel really great. Your uterine level, if we're doing a lining check, which, you can let your practitioner do that. If they get, nervous, well, let's check a uterine lining. If I have some women on some compounded progesterone because that's the only thing that they've tolerated, we have that discussion. Hey, listen, maybe in 3 months or 4 months, we should probably look at that lining and make sure it's okay.
Yeah.
And that's okay
Yeah.
because we're learning. We're learning a lot because we've had 24 years of nothing.
So true. That's so true. Well, Rebecca, we talked about before we got started that we could literally make this a
Yes.
multi-hour session because even before we started this, we were
I
already
know.
going, right? Like, and I think the three of us could keep going forever. So, in respect of your time and the people listening who don't are like, gotta go.
I know, right? Like, can we
Um,
listen to this on one? Listen to it on 1.5, you guys.
yes,
Seriously, that's why I
exactly.
listen to everything on 1.5.
Oh, that's good. That's good.
Exactly. Well, I was going to ask you for one piece of advice. We won't let that one be it. If you
Yes,
have one piece of
yes,
advice for women,
yes.
especially around hormones during this phase in their life, what would it be?
Boy, it's probably not just one.
I
Me and
know
my
it's so
long-winded
hard.
answers. It really is to give yourself grace. If you're a perimenopausal patient, woman, give yourself some grace. You're not going crazy. Your hormones are fluctuating. Don't let anyone gaslight you and just find someone. Put the research in, ask the questions, and if you're able to put the investment in, it may be worth it. For our menopausal patients, don't be scared. Ask the questions. No one should ever blow you off for your symptoms. And I think, educate yourself and find someone that you resonate with, and you don't have to stay with them. Don't stay with them because you feel bad. Find someone else that you connect with and that you click with. So I know that was a lot of advice, sorry, but
That was perfect. I mean, absolutely. I mean, if Angie and I do anything, it's about advocacy, standing up for yourself, and
yeah.
educating,
Asking the right questions.
asking the right
Yeah,
questions.
yeah.
Absolutely. So we are, yeah, we're right on board with that. So I really appreciate your time. I mean, it's just amazing to have you back, and hopefully we will continue doing that on a regular basis because
Yes.
I think that just this is just such a great way of being able to just dive right in, get into some answers, and get rid of all the fluff that's out there.
Yes,
So really appreciate
absolutely.
you being so real about all of this. So thank you so much for joining us. If you like this episode, please make sure you give it a thumbs up, add comments in the comment section, and please, as always, subscribe so that we can continue to get more amazing experts like Dr. Rebbecca Hertel on our show. So thank you again, Rebecca. This was amazing.
Absolutely. Thank you
Thank
both. You
you.
guys, and have a wonderful weekend.
Thanks, you too.
Thank you. You too.
Thanks, everyone.